Welcome back, students, to this explainer for Decode Healthcare with Harshal. Before we unlock today's crucial coding concepts, I need to ask a quick favor. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, let's dive right into this masterclass. On today's agenda, we are going to unravel present on admission or POA indicators, dive into hospital-acquired conditions and their reimbursement impact, walk through some real-world clinical examples with CDI strategies, and finish up with a summary and a teaser for next time.
Section 1, Intro and Recap.
Just to ground ourselves before we move forward, let's quickly recap Part 41. We established that within major diagnostic categories, DRGs are split into either surgical or medical tiers. And what actually dictates that split? Well, it's based entirely on whether a major operating room procedure was performed. If a significant OR procedure is present, boom, it goes to a surgical DRG. If not, it just defaults to a medical DRG. Simple enough, right? Now let's add a new layer of complexity, the exact timing of when diagnoses happen. Section 2, Present on Admission or POA reporting concepts.
So we need to completely understand the definition of present on admission. According to the coding guidelines, a condition is only present on admission if it existed at the precise, exact moment the physician wrote the order for inpatient admission. It's literally a rigid timestamp. I mean, even if the patient started showing symptoms in the ER or the observation unit or during an outpatient surgery, if it was present when that formal inpatient order was finally signed, it officially qualifies as present on admission.
Now, you don't just get to guess here. There is a strict system of 5 official reporting flags, and every single diagnosis on a claim needs one. Y means yes, it was present. N means no, it wasn't, meaning it developed after they were admitted. U is for when the documentation is just unknown or insufficient. W means it's clinically undetermined by the provider. And 1 is reserved for conditions that are completely exempt from POA reporting, like certain congenital defects.
And this right here is exactly why clinical notes are the absolute backbone of what we do. The provider's documentation has to explicitly establish the timing of when symptoms started, because that exact timing dictates which of those 5 flags you're going to assign. If the notes are vague, well, we're left completely in the dark, and that triggers some massive compliance risks and potential financial losses.
Section 3, Hospital-Acquired Conditions, or HACs, and Reimbursement Impact. This builds perfectly into our next point. What exactly is a hospital-acquired condition? Basically, it's a condition that developed during the hospital stay, so it gets that POA flag of N, which CMS has designated as reasonably preventable as long as you're using evidence-based care. In CMS's eyes, look, if the patient didn't come in with this condition, the hospital absolutely shouldn't be rewarded with extra payment for having to treat it. So what are they looking out for? Here are the high-cost, high-volume HAC categories that CMS aggressively targets. We're talking about severe stage 3 and 4 pressure ulcers, catheter-associated urinary tract infections, or CAUTIs, and vascular catheter-associated infections like CLABSIs. The list also includes things like in-hospital falls that result in trauma, manifestations of poor glycemic control that pop up in-house, and specific surgical site infections. These are major red flags when it comes to quality of care. Which brings us to the multi-million-dollar question for hospital administrators. How exactly does an N indicator for one of these HACs actually penalize the final DRG payment? Let's see this penalty mechanism in action. Imagine a patient is admitted, and during their stay, they develop a new acute deep vein thrombosis, a DVT. Now, normally, an acute DVT acts as a major complication or comorbidity, an MCC, that usually drastically increases the DRG relative weight and the payout. But because it has a POA of N, meaning it was acquired in the hospital, the Deficit Reduction Act policy kicks in. It completely strips away its MCC status for payment purposes. So the case drops down to a lower severity tier, and the hospital's reimbursement is significantly reduced, even though they spent heavy resources treating that DVT. Crazy, right? Section 4, Clinical Examples and CDI Documentation Strategies. To really grasp the gravity of this, let's look at some real-world scenarios. Take Scenario 1A. A patient is admitted with an unstageable pressure ulcer that's already documented. The POA is Y. Because they came in with it, the hospital keeps the complication status, and reimbursement goes up to cover the complex wound care. But in Scenario 1B, the patient comes in clear, but then develops a Stage 3 pressure ulcer on day 3 of admission. Now the POA is N. This is an HAC penalty. It won't increase the DRG weight, the hospital has to absorb the cost of treating it, and they take a huge hit on their quality metrics. Here's another super common one. Scenario 2A. Patient is admitted with a community-acquired UTI. POA is Y, and it's treated medically with zero penalty. But in scenario 2B, we have a post-operative catheter-associated UTI, a CAUTI, identified on hospital day 4. Because that catheter was placed in the hospital and the infection started during this day, the POA drops to N. It's now a penalized hospital-acquired infection, and that complication revenue is totally gone.
So what are you supposed to do when the documentation is just completely ambiguous during that critical admission window? We literally can't just guess. This is where clinical documentation integrity, or CDI, steps in. If a condition like acute kidney failure is noted, but the timing is muddy, CDI specialists have to send a compliant, non-leading query exactly like this. Was the acute kidney failure present on admission, Y, or not present on admission, N? Phrasing it this exact way gives the provider the choice without leading them, making sure you get accurate, compliant billing.
Section 5, Summary and Teaser.
Okay, let's wrap up. Here is your bottom line for Part 42. POA flags identify if a condition existed at the exact time of the formal admission order. Those 5 flags, Y, N, U, W, and 1, entirely dictate the DRG logic. Remember, HACs are preventable conditions developed during the stay, and getting an N on these strips a diagnosis of its CC or MCC status, which slashes your payment. You've got to master these indicators and use targeted CDI queries to accurately reflect patient severity and avoid those unfair penalties. Coming up next time in Part 43, we're going to break down major diagnostic categories 1 and 2, which cover nervous system and eye disorders. Until then, I want you to ask yourself, what hidden documentation gaps might be costing your facility millions right now? And of course, I have to remind you one last time, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Herschel. Keep coding accurately, and I'll see you in the next one.